Thank you again for the introduction, and thank you, Eric, for your very nice presentation and your impressive data, which I will in part repeat, but I will also come up with our own data. The background for therapy with lutetium octreotide is that the majority of neuroendocrine tumors express somatostatin receptors. We heard from Eric Cranning that treatment with radio-labeled somatostatin analogs has been used in patients with neuroendocrine tumors for more than 10 years, actually more than 20 years now, but with lutetium at least more than 10 years. Here is just to show that carcinoids, midgut carcinoids express somatostatin in more than 90% bronchial and about 2/3 pancreatic endocrine tumors, gastrinomas more than 90, insulinomas far less. But also other neuroendocrine tumors such as paragangliomas and pheochromocytomas have a high expression of somatostatin receptors, and in medullary thyroid carcinomas in as much as 2/3. This is the Cranning scale for grading of radionuclide uptake at somatostatin receptor scintigraphy, where 0 is no uptake, 1 is suspected, 2 is accumulation in known tumor lesions up to normal liver uptake, and 3 is uptake more than normal liver uptake, and 4 is very high, equal to this uptake in spleen and kidneys. Here is an example of a patient with a midgut carcinoid. This is an octreoscan scan with very high uptake in liver metastasis and also lymph node. Do I have a pointer? Pardon? Do I have a laser pointer? No, I don't. Doesn't matter. This is another example of a patient with a midgut carcinoid, liver metastasis and bone metastasis. Thank you. High uptake. This patient received lutetium. The previous patient did not, actually. Targeted radiation therapy can be performed with indium DTPA octreotide, yttrium octreotide, lutetium octreotide, MIBG, and also yttrium-90 Ceraspheres or Theraspheres. And I will only discuss lutetium today. Here you have the various isotopes. Indium is a beta emitter, gamma emitter, which works by audio electrons. Yttrium and lutetium are beta emitters. Yttrium has a half-life of about 2.7 days and lutetium of 1 week. And the range is longer for the yttrium particles, up to 1 centimeter, but only up to 2 millimeter for lutetium. Of note is that lutetium has a weak gamma emission, which allows us to take pictures after the treatments. And then we have iodine, which I will not talk about. It's also emitting beta particles. Indications in our institution for therapy with lutetium octreotide are the following: carcinoids, pancreatic nets, or pheochromocytomas with uptake at least grade 3 or 4 on octreoscan. Bone marrow and kidneys are the dose-limiting organs. We require hemoglobin of more than 100 grams per liter, white blood cells more than 3, neutrophils more than 1.5, platelets more than 100, and the creatinine less than 110 micromole per liter, a GFR more than 50 milliliter per minute, and the bilirubin less than 50, and liver enzymes less than 5 times upper reference limit, and life expectancy more than 3 months. And the contraindications are tumors accessible to surgery or radiofrequency ablation, decreased bone marrow renal function, moderately or severe decreased liver function, as I said. Massive liver metastasis with high uptake may be a contraindication because of the risk for severe liver damage. Inability to be isolated for 24 hours, inability to manage the personal care, and proliferation more than 20 to 30%. We discontinue sandostatin LAR or somatulin autogel a month before treatment. short-acting sandostatin in the evening before, and Intron A 1 week, and Peg-Intron 2 weeks before treatment. We premedicate with tropicitron 5 mg and betamethasone 8 mg. We now give an amino acid solution 2 liters for 8 hours. Previously we gave 1 liter for 4 hours, but we have increased that, and we isolate the patients for 24 hours. And we have a protocol for individualized dosimetry where we scan the first treatment after 0, 24 hours, 4 days, and 7 days, and after the following treatments directly after treatment and after 24 hours. And the maximum dose to kidneys are 23 gray, and to bone marrow 2 grays. We give 3 to 7 treatments with 6 to 12 weeks interval, and the maximum dose is 7.4 gigabecquerel per treatment. We have so far treated 197 patients. Of those, 84 midgut, 12 lung, 15 rectal, 39 non-functioning, EPT, 6 gastrinomas, 6 glucagonomas, 2 insulinomas, 4 pygangliomas, and 711 treatments, and we have follow-up data of 161 patients with a mean of 1 year. And the results you can see here, we have one complete remission, which is 1%, 29 partial remissions, 14% minor response, 52% stable disease, and 5% progressive disease. And these are best responses, and they are about the same as Professor Krenning just gave us. And 29 of the patients with response have later progressed. This is a patient with a pancreatic endocrine tumor, which you can see before treatment and after clearly decreased uptake. And this is a patient with a bronchial carcinoid after first, second, third, fourth, and fifth treatment with a clearly continuously decreasing uptakes in the metastasis and fewer metastases. This is the same patient. And this is a patient with an insulinoma, which you can see full of metastasis, and after 2 treatments, this is after the second treatment, no metastasis. Regrettably, these patients later recurred. And the side effects are mild. As you can see, grade 3 to 4 thrombocytopenia and 3%, leukopenia and neutropenia and 6 and 7%, and renal in 17%, all except 2 grade 1. And 1 patient has died from pancytopenia, and 1 patient has developed an acute leukemia. I will skip this Rotterdam experience because Professor Krenning has already gave us them, but as you can see here, this is Dick Kvekebom's paper from 2008, and they are roughly comparable to our data. Median time to progression was 40 months, and median overall 46 months. Median overall survival from diagnosis 1 year, and the survival benefit between 40 and 72 months. And higher remission rates in patients with high uptake on octreoscan and high Kanowski performance status, shorter time to progression in patients with bone metastasis, extensive liver involvement, and gastrinoma lymphoma tumor types. And the side effects we have also heard about, severe delayed toxicities in 9 patients. This is interesting. I gave these figures previously today. Bronchial carcinoids, 9 patients, 5 with partial response, 1 minor response, 2 stable disease, and 1 progressive disease. And also 5 patients with gastric carcinoids, 1 complete response and 1 minor response. And the quality of life, I will just say shortly that lutetium, this is also from Professor Krenning's group, lutetium improved quality of life and several functions and reduced symptoms in patients with metastatic neuroendocrine tumors, but especially in those with proven tumor regression. Here are a summary of therapy with inject tumors treated with different radiolabeled somatostatin analogs. And what you can see here is that the response rates in patients with yttrium and lutetium are roughly the same, but clearly were inferior with MIBG. And the response duration with yttrium is about 30 months, and with lutetium, 40 months. The response rates with indirimoxeprotide are clearly inferior to those with yttrium and lutetium. And the side effects are slightly more with yttrium than with lutetium. Conclusion: somatostatin receptor-mediated treatment provides a feasible, widely well-tolerated therapeutic option for patients with neuroendocrine tumors. Beta emitters are promising. Treatment with combination of yttrium and lutetium may provide even better tumor control, just as Eric Krenning said. The best time for radioisotopes in the treatment of these patients is still, however, to be established. In combination with chemotherapeutic agents such as capecitabine, aiming at potentiating the effect, is interesting. Which patients should be treated? This is important. Patients with high uptake on octreoscan, at least 3 or 4. Patients in good general condition. Patients with normal bone marrow and renal function. Patients with disease outside the liver. Patients with rectal or hindgut carcinoids, there we don't have any good therapeutic options, and these patients respond very well. In patients with bowel carcinoids, we treat them with lutetium mainly if they progress on interferon plus somatostatin. We treat some patients who primarily with lutetium. And in Foga tumor, it can be considered first-line treatment. And which patients should not be treated? Well, patients with inhomogeneous optic on octreoscan, patients in poor general condition, patients with impaired bone marrow renal function. If they have extensive liver involvement, we must be careful unless progression elsewhere, and patients who are candidates for surgery and or radiofrequency ablation. I would just say a few words about the study and the registration. We have the same problem as we have in the Netherlands. The Swedish Medical Product Agency will not allow us any longer to give this treatment unless we perform a study. So we are actually starting a study which is a one-arm study. All patients receive treatment. The only difference compared to before is that you have to sign that you're allowed to participate in a study. But the treatment is the same, the protocol is the same, but it's called a study. Thank you for your attention.